Hey class, it's Dr. Dorf. Want to do a quick lecture over osteoarthritis, osteoporosis, low back pain, and ankle pain and sprains. This is to supplement the PowerPoint you see in front of you, which is musculoskeletal problems in primary care. So let's start off talking about OA, or osteoarthritis. First off, it's the most common joint disease in North America. My text, it talks about just the most common form of arthritis, most common form of joint disease in North America, period, and is the most common form of arthritis. Degenerative condition that manifests itself without any systemic manifestations or acute inflammation. Usually the distal interphalangeal joint is the most common OA site. However, the most problematic joint involvement usually is hip and knee. So typically you're going to have discomfort that increases as the day progresses. There's minimal morning stiffness in contrast to rheumatoid arthritis, where morning stiffness is usually extremely problematic. So that's kind of what you're going to see in terms of OA. And this talks about that stiffness may be most noticeable when you wake up in the morning, but again, usually if there is stiffness, it will occur in the morning, but it's going to be minimal, especially compared to RA. Risk factors for osteoarthritis, family history is going to play a role. You're also going to have obesity, which is likely the most common personal risk factor, especially when you're dealing with your hips and knees, anything below the waistline that's load-bearing. Also in OA, the articular cartilage becomes very rough and it wears away. So someone who's had a long-standing history of contact sports participation or previous injuries, you'll see that occur as well. As a result, you'll often get bone spurs that are going to form, and the synovial membrane is going to thicken, and as a result, the joint space tends to narrow significantly. And this talks about that it does become degenerative, worsening over time, and that the joint stiffness will eventually become severe enough where it can make some daily tasks difficult. So in terms of radiologic findings in OA, you're going to have narrowing of the joint space and increased density of the subchondral bone. You may see bone cysts and osteophytes that are often present. And typically, though, with OA, and it mentions it at the end of x-rays here, about half the patients you will have radiological findings, but they don't have any symptoms. And OA is, like I said, typically a non-inflammatory disease, so stuff like SED rate or CRP levels, which are both inflammatory markers, are typically normal. And then in contrast to RA and lupus, ANAs, rheumatoid factor, and any other marker for a systemic arthritis are going to be absent, unless there happens to be a current disease with it. So you're really basically ruling out other issues, but you aren't necessarily going to have, again, those lab values be positive in the setting of OA. So what do we do for these patients? We're basically looking at preventing further articular cartilage destruction, try to minimize pain and enhance mobility as best we can. Lifestyle modifications, weight loss, swimming, that's a good way to exercise and maintain joint flexibility without putting stress on load-bearing joints. A lot of patients will talk about that they find heat works better to help minimize pain and discomfort. and then after activity, applying ice. Again, you can go back and forth. What you need to know in terms of guidelines. For osteoarthritis of the knee, guidelines from the American Academy of Orthopedic Surgeons recommend the use of NSAIDs, oral or topical, if tolerated. Of course, if we have any underlying GI issues, history of ulcers, so on and so forth, if we're taking antiplatelet medications, of course, all that goes out the window. And tramadol or Ultram for controlling pain. And you're going, okay, why NSAIDs if you just said this really isn't an inflammatory disease process? It's there, it's a minor contributor, but NSAIDs tend to work better. It shows than acetaminophen, which I do have listed up here, but it can be used. But NSAIDs are frontline from the American Academy of Orthopedic Surgeons, followed by Ultram. But as you know, it's an opioid analgesic. It's effective for treating moderate and moderately severe pain. However, long-term use can lead to dependence. You got to be careful if they're on a SSRI, increased risk of serotonin syndrome there. SNRIs are sometimes prescribed for OA. Duloxetine, you may notice Cymbalta, is approved for the treatment of chronic arthritis pain. But again, you're dealing with an SNRI. If they can't tolerate it, then you may have a difficult time kind of getting them off. You can also, by the way, before we move on from that, you can do intra-articular corticosteroid joint injections. However, the American Academy of Orthopedic Surgeons does not recommend for or against the use of joint injections because they say there's a lack of compelling evidence when comparing the benefits with the risks. Also, the Academy does not recommend using hyaluronic acid injections for treating symptomatic osteoarthritis of the knee. Again, there's just a lack of evidence. And again, it's going to get to the point where they're going to need knee or hip replacement, total knee or total hip. Usually the determination is made and according to guidelines when more than 80% of the articular cartilage is worn away. So that's OA. Let's talk about osteoporosis. So it's a disorder of bone thinning in which bone absorption exceeds bone formation to the degree that bone density is insufficient to meet skeletal needs. And that's why we get DEXA scans or bone density scans, right? So you have the definitions up there in terms of normal osteopenia and full-blown osteoporosis. It all has to do with the T-scores. And basically, you'll see a lot of this talks about young adult and standard deviations. Basically what it's saying is osteoporosis, basically it's defined as a bone density more than 2.5 standard deviations below the average bone mass for women who are younger than 35 years old. So for every reduction of bone mass by 1 standard deviation, the relative risk of fracture rises by 1.5 to 3 times. So that's why we get DEXA scans. Again, we're trying to look at risk for fracture down the road. Estrogen deficiency, very potent risk factor, and is most common in postmenopausal women. In fact, by the age of 80, average woman has lost more than 30% of her premenopausal bone density. You'll see that reflected on imaging. You'll see where the bones look extremely gray, as opposed to young, healthy bone looks very white on plain films. So here's a list in terms of who we should test. It's not exclusive to women. You can also see it in men as well. So again, patients with osteoporosis, hip, wrist, and spinal fractures most commonly occur. All bones can be at risk. A lot of times there's no symptoms whatsoever, but sometimes you'll have people complaining of backache, non-specific pain or whatnot. Anyway, and again, here's more risk factors. You can see a lot of this has to do with age and just a lifestyle and body habitus, quite basically. So we're going to treat patients with that T-score that's less than 2.5 if they've had a previous history of a hip or vertebral fracture, and then postmenopausal women and men over the age of 50 that have a 10-year fracture probability greater than 20%. So what are we going to do? How are we going to treat them? Latest recommendations from the National Osteoporosis Foundation. We want to get calcium into them. So the calcium intake goal should be the equivalent of 1,000 milligrams a day for men between 50 to 70. And the dose should be 1,200 milligrams a day for women 51 and older, and men older than 70 years. A lot of that they're going to get through diet. But if not, then you need to provide supplementation. And then vitamin D, minimal dose is going to be 800 units. But you can go up to 1,000 international units daily. That's recommended for all adults older than the age of 50. Of course, higher doses will be needed for those that have a true vitamin D deficiency. So, by the way, there's also many tests that are available to evaluate osteoporosis risk or progression of the disease. Most commonly, it's going to be the DEXA scan that was on previous slides. You may also see CT used, but of course, a lot more radiation CT scan compared to a DEXA scan. Plain films, not necessarily going to be frontline and really should not be used for screening or evaluation of osteoporosis because the disease can't be detected until 40 to 50% of the bone mass is lost. And then just back to treatment a little bit. When taking calcium supplements, postmenopausal hormone therapy can help reduce the risk of postmenopausal fracture by up to 34%, although you have to kind of raise risks versus benefits. There are selective estrogen receptor modulator such as Avista, raloxifene is another name for it. Helps to preserve bone density. It doesn't attach to the estrogen receptor sites in the breast or uterus, so it's often considered an alternative to hormone therapy. Parathyroid hormone, which is right here. One that you'll most commonly see will be Forteo. It's an anabolic agent, and it can reduce the risk of vertebral fractures by about 65% in patients with osteoporosis. Typically, though, that treatment's going to be reserved for women with a very, very low bone density or if they had a prior fracture. And usually you're going to limit course of treatment for 2 years because there is an increased risk of osteosarcoma associated with Forteo or parathyroid hormone. Then you got your biphosphonates up here, which I've listed a few: Fosmax, Boniva, Actonel, Reclast is one that I left off. They inhibit the resorptive activity of osteoclasts. They can help modestly increase bone mass and significantly reduce fracture risk. You can have some drug-induced esophagitis. So patients that are taking an oral biphosphonate should be cautioned to take the medication in the morning with a full glass of water and wait at least 30 minutes before eating food, other liquids, or other medications. Very similar to something we already covered in endocrine, someone who is taking levothyroxine or Synthroid. So they kind of have that in common. Reclast, that's an infusion, typically going to be administered by rheumatology. It's given once a year every 2 years. And again, you're going to have really much of a oversight of that in a primary care or urgent care setting. And then we also have up here, we have calcitonin. It's another anti-resorptive medication. It seems to be the most helpful in building vertebral bone, although it has FDA warnings on it as well. That risks associated with calcitonin use outweigh the benefits in treating osteoporosis. Again, because they found higher rates of malignancy among patients that took calcitonin. And then finally you have Prolia. Down here, it's a receptor activator of nuclear factor kappa B. Don't worry, I'm not going to make you be responsible for that. Just know that it reduces the incidence of vertebral fractures by about 68% in people with osteoporosis. It's a sub-Q injection. It's given every 6 months. And with all of these therapies that are mentioned up here, you need to continue calcium supplementation and vitamin D. Shin splints, if you've ever ran, you know what shin splints are, so I'm not going to dive into too much detail on that. Let's get to the ankle. That also was one thing that during assessment class seemed to kind of trip some people up. So when we're dealing with ankle sprains, which is most commonly what you're going to see in the primary care setting, it's basically graded according to presentation and underlying degree of ligamentous injury. So you need to know your anatomy. Here are the 3 most common ligaments that are affected during an ankle sprain, with the ATF, the anterior talofibular, being the most commonly injured, especially during an inversion injury. So you have the ankle anterior drawer test, which you will utilize to assess for excessive laxity. You'll see a lot of anterior motion, excessive anterior motion with a grade 3 sprain. I don't think I put that on here. Yeah, there we go. 1 through 3. Anyway, so a lot of laxity with a grade 3 sprain. You're going to do immobilization. Grade 2 and grade 3 injuries, occasionally associated with persistent joint laxity and risk of future ankle sprain. So you try to keep those folks, if they're grade 2 or they're grade 3, definitely they're going to be out of sports for 2 to 3 weeks because they are at increased risk of a re-injury. And like I said, at grade 3, you're probably going to immobilize. Ottawa ankle rules. You'll rarely see these in clinical practice. You need to know them for purposes of this course and for boards. But ankle and feet can just be tricky in nature. I've had people come into the clinic who have walked in just fine. There's absolutely no soft tissue swelling or ecchymosis, dependent edema, anything like that on exam. Put them through range of motion, everything's just fine. You get an x-ray and they've smoked their distal fibula, and vice versa. People come in who just can't bear any weight. Every single test that you perform on them, they want to kick you in the face and come flying off the table, and you have perfectly normal imaging. So I don't put a lot of stock into the Ottawa ankle rules, but you need to know them in case you see it on a board question. And again, treatment's basically going to be your RICE therapy. And again, second, third, third definitely are going to be immobilized and sent to ortho. Second, you can get away with probably crutches, maybe compression sleeve, and bring them back and go from there. All right, low back pain. Outside of knee, which I covered in a previous lecture, is going to be extremely aggravating in the clinical setting. You'll see it come in many shapes, forms, and fashions. Rarely will you see someone do what I did in terms of full-blown cauda equina and have cord compromise actually coming to the clinic, but that's just because I'm trendsetting and groundbreaking. Anyway, it is again, very common. You're going to see it. In fact, there's data that shows that there's a lifetime prevalence between 60 to 90%, meaning that at some point in every patient's life, there's a 60 to 90% chance that they're going to hobble into your clinic with low back pain. Majority, 90% of patients with low back pain. Symptoms are very short-lived, resolve within a month, and that would be even doing without any real specific therapy. Yeah, of course, you do have people who have chronic low back pain and failed back syndrome, people who want to come in and want disability, all that type of fun stuff. It's aggravating. You'll have to deal with it. Anyway, so we're going to have lumbosacral strain, disc herniations and resulting lumbar radiculopathy and sciatica are going to be what you're most commonly going to see. The lumbosacral strain is by far and away the most common reason for a patient to present to the primary care setting with acute low back pain. So, typical scenario, you're going to have someone coming in complaining of stiffness, spasms, reduced range of motion. The erector spinae muscle is often the biggest offending agent. Sitting aggravates the pain, puts more stress on the low back than any other position. So patients that come in and say that they get relief when they've been sitting for a long period of time. Not saying they're full of it, but yeah, they're full of it. So usually there's a more relief with patient lying supine, especially on a firm surface. In terms of precipitating events, it's really actually just reported by a handful of patients because lumbosacral strain is usually the culmination of many events. Repetitive use, repetitive motion, overuse, improperly stretched muscles, people with poor conditioning, especially with their core muscles. Core controls the back, it supports the back, right? Poor posture, scoliosis, spinal stenosis, there you go. So during physical exam, again, you're going to have some paraspinal muscle tenderness and spasm. Usually worse, L3 to 4. You'll have decreased lumbosacral flexion and maybe some lateral bending as well. The neuro exam is pretty much going to be normal in a lumbosacral strain. If there is a neurologic abnormality demonstrated, then you kind of need to be thinking about lumbar radiculopathy. So in terms of working things up for a lumbosacral strain, imaging wise, you're really not going to do it. Radiographs aren't going to really show you a whole lot unless you have a very high suspicion for fracture or something like that. But in the absence of that, nothing's really going to be revealed by plain films. So again, not routinely indicated unless you have some neurofocal deficits that are noted. And we're going to do analgesia. You're going to do patient conditioning, physical therapy, ice heat, muscle relaxants. Do not limit physical activity. Do not let these people go home and lay in bed all day long, which is what they want to do, or sit around all day long. That's going to be the worst thing that they can do. You need to have them going. Lifting restrictions, that's reasonable, but laying around for 3 weeks and drawing short-term disability or FMLA, no. All right, lumbar radiculopathy. So now we're dealing with irritation, damage of neural structures, such as discs or herniated discs that's irritating nerve roots. Of course, you have nerve roots coming out on either side of the spinal column, left and right side. Usually this is going to occur after years or frequent episodes of back pain caused by repeated damage to the annular fibers of the disc. And like I said, this is much less common than lumbosacral strain as a cause of low back pain in the primary care setting. Risk factors, we're going to be looking at smoking, higher risk factor, diabetes, obesity. Usually you see it in the male gender. And of course, you're going to have people coming in a lot of times saying my sciatica is acting up, and that's just because the discs tend to rupture at L4-5 and L5-S1 with the posterior lateral aspect of that disc protruding. So that's going to come into contact with the sciatic nerve. And basically, sciatica is basically, the definition of it is neuralgia along the course of the sciatic nerve. And it's, like, again, due to pressure on the nerve roots, most commonly from a herniated disc. You can also have it in the setting of a spinal stenosis or a compression fracture. And the degree of pain, it's going to vary according to the degree of nerve involvement. It can range from mildly bothersome to being extremely painful and incapacitating. And again, here's where we'll, on examination, be very similar to a lumbar sacral strain, but you're going to have a little bit of altered neuro exam. Some of our more specific tests, straight leg raise, crossover leg raise. Remember, we don't care if they talk about that they feel stretching or pain or discomfort in their low back. We're looking for radiculopathy, right? It should light them up. You'll also have decreased deep tendon reflexes. So MRI, most common, unless they have contraindication, metal implanted anywhere in their body, they're rocking a plate pacemaker, something like that, in which case you're going to do CT. Keep in mind with radiculopathy, and here's in terms of what you're going to look at in terms of the nerves that are affected. So pretty much just by knowing your dermatomes, and knowing what deep tendon reflex assesses said dermatome, you can pretty much predict what's going to show up on the MRI. The MRI is not there for you, it's for the neurosurgeon or pain management specialist that they may go see down the road. Anyway, treatment, keep in mind that since we're dealing with neuralgia, a lot of your typical analgesics aren't going to work real well because they don't bind really well to nerve pain receptors. So you need something that really binds well to that, gabapentin or Lyrica. Again, this talks MRI's preferred modality, CT if unable to. Spinal stenosis, mentioned this a little bit already. Usually going to be older patients. They're going to be older than the age of 50. Reason why you're going to see stenosis in patients that are over the age of 50 is because the discs, they contain water. They're a very gelatinous material. And as we get over the age of 50, those discs will contain a lot less water and they become more fibrous. But on the plus side, the risk of disc rupture significantly starts to decrease after the age of 50. But those are the ones that will get the spinal stenosis. So there we go. More musculoskeletal lectures to come to accompany some of the PowerPoints and readings that I have posted within this module. Hope this is helping.